session is again going to be for 15 minutes, and then we'll have a session of question answers collectively at the end. So over to Dr. Vijaykumar. He's he's from Apollo Specialty Hospital Diabetes Medicare Center, Chennai. He has many papers published in various journals, and he's got the Best Doctor Award from Dr. NGR Medical University. Dr. Vijay Kumar, please.
Dr. Vijaykumar, yes.
Yeah. Dear chairpersons and co-speakers of this particular session, it's a wonderful session. Namaste and good evening to all of you and all to the delegates as well. And my heartfelt thanks to my good friend Dr. Banshi Sabu, who has given me this opportunity. In the next 15 minutes, it's a very important and very novel topic that is given to me. Metformin controversies, a review. First love never dies, isn't it? So it is 60 years, more than 60 years since metformin has been used, and it's beyond glycemic control. You can see that it is usefulness in PCOS, in cancer, in aging, microbiota, cardiovascular disease, pregnancy, you name it, everything, including type 1 diabetes. They're supposed to be having a benefit, especially when they have insulin resistance along with that. It's going to be supposed to be useful. So it's something extraordinary, the drug is such an extraordinary one. No doubt why every association in the world has said that recommended metformin as a preferred initial pharmacotherapy for type 2 diabetes. Now, it's a very old drug. It is more than 65 years old by now, but with a lot of new tricks, if you can see that. Straight from the way it acts and the metformin in cardiac events, in pregnancy, it may cause B12 deficiency, lactic acidosis, kidney, and so many things, but it is still, after usage of 65 years, it's still mired with enough controversies and debates. And so the question often, of late, recently, in the last 1 year, asked is that, should metformin remain as a first-line therapy in type 2 diabetes? Is change overdue? Now, do you think we need to change it from the first-line therapy that metformin has been all these years? Well, let us review the facts. First, let me look into critical appraisal of metformin data in the form of metabolic parameters, how it pathophysiologically, glycemic durability, CV outcomes, if there is any benefit at all. Now, if you look into the insulin sensitivity, because basically metformin, all of us know, is an insulin sensitizer. Metformin does not improve muscle insulin sensitivity. It is measured by euglycemic clamp in type 2 individuals and in the absence of weight loss. In the weight loss, you can see that it doesn't improve the muscle insulin sensitivity. But how it works is basically it reduces the hepatic glucose output, where it sensitizes the hepatic tissue, but no skeletal muscle tissue. This is what we need to understand. Now, way back in 1998, the Lancet has published that effect of intensive blood glucose control with metformin on complications in overweight patients with type 2 diabetes in UKPDS. What it has been, if you can see the statement that again, since intensive glucose control with metformin appears to decrease the risk of diabetes-related endpoints in overweight diabetic patients. Mind you, that is in overweight diabetic patients, and is associated with less weight gain and fewer hypoglycemia than our insulin and sulfonylureas. So it may be the first-line pharmacological therapy of choice in these patients. So the controversy here is that, is it only for overweight and obese patients, or it can be used for every patient? And then maybe is a catchword there. Now, Metformin is a very effective anti-hyperglycemic drug that even sulfonylureas are equally effective and durable as well. Um, Let us compare with another insulin sensitizer, pioglitazone. If you look into that mean HbA1c reduction, both are equal, 1.41 versus 1.5. Fasting blood glucose reduction equally good, 205, 203. But look at the HDL and fasting plasma insulin. There is no change with metformin, whereas by using glitazone, another sensitizer, compared to metformin as a sensitizer, there is a reduction in plasma insulin and increased HDL as well. Comparatively, it is better with pioglitazone compared to metformin. So there's been controversy that may not be effective as a good insulin sensitizer. Now we have also the latest drugs such as GLP-1 receptor analogs, SGLT inhibitors are seems to be more superior metabolically compared to metformin that it has shown. As far as the durability is concerned, all of us know that a monotherapy with metformin at the end of 5 years, if you can see that it is inferior to thiazides. No doubt why in most of the studies, like including UKPDS and ADOPT trial and other studies, have clearly shown that effect of metformin on HbA1c, because metformin does not affect the muscle insulin sensitivity or beta cell function. Following an initial decline after metformin administration HbA1c, it rises progressively in type 2 diabetic patient. This is the fact that is happening. But still, I would like to say that please don't think it's a negative information that I'm giving. A metformin in combining with other drugs is a very good combination that we can think about. We cannot imagine metformin without able to control diabetes without metformin. Now, with all those things, we can see that, okay, look at the beta cell preservation. And this is the most important thing. Suppose, in the natural history of diabetes, over the time, the beta cell numbers comes down. And all of you know that at the time of diagnosis, only 50% of the beta cells are available, and over the time they also get reduced. One of the reasons why beta cells go either to apoptosis or to hibernation is because of the glucotoxicity and as well as the lipotoxicity of the beta cells. So metformin and TZD were able to give both reduction in glucotoxicity, reduction in lipotoxicity, and so that it rests the beta cell. This is a very, very important thing. So, though it is beta cell sparing, but it is still a useful drug in presence of the beta cells. Now, whenever we are trying to treat diabetes very less than 7, we always get into hypoglycemia and also increase in weight gain that has been known that. Now, do you think that only metformin, which is weight neutral drug, which is available? Yes, we have glitazones, though they have increase in weight but better insulin sensitizer. Gliptins are also weight friendly. Alpha glucosation is weight friendly. Again, they can reduce the weight as well. And GLP-1 analogs as well as SGLT inhibitors are there to reduce the weight. So, as far as weight is concerned, there are superior drugs to metformin. Now, as far as the cost is concerned, yes, every time, every part of the world, people say about the cost of metformin is a big advantage. Even sulfonylureas are equally cost effective in our country. Nevertheless, though the debate, the controversy has been there, what we need to understand is that metformin is beta cell sparing. It is in fact beta cell protective. It is weight neutral. In a few patients, weight reduction has been there, and especially in overweight patients. And it is metabolically friendly. What you need to do, it doesn't disturb the metabolism. Though you can see that it may not do too many things like other sensitizer, but it is still a metabolic friendly. It doesn't disturb the metabolism, and it's a very, very good anti-hyperglycemic drug. So I think we need to rest the controversy about the critical appraisal of the metabolic factors to rest now as far as metformin is concerned, but still is a good drug to think about. Now, whenever we talk about any molecule, anti-diabetic molecule, we always think about safety and protection to the heart. Now, the UKPDS has always been projected to state that, okay, metformin is very cardio-friendly, it reduces the microvascular disease, apart from glucose-lowering medication. But if you can see that in 2009, diabetology, he said that however, the sample size was relatively small by current standards in UKPDS. So these findings require confirmation. This is a controversy that has been brought in 2010. Apart from these things, there are several meta-analyses which I have done. At least I will show you two meta-analyses. You can see here one meta-analysis regarding the uh, um, uh, uh, cardiovascular events and mortality. If you can see that the 35 clinical trials, about 7,000 plus patients in the metformin group, and control group is about 11,300. So that is comparator, metformin versus comparator. There is no CV benefit. And there is overall effect on CV events, no significant benefit. Benefit depends on duration and age. So it has been like that. And another meta-analysis regarding the all-cause mortality and CV mortality in about 13,000 patients out of 13 trials has clearly shown that the primary endpoint of all-cause mortality and the CV death and secondary endpoint of myocardial infarction, stroke, congestive cardiac failure, peripheral vascular disease, leg amputation, microvascular, all those things, no effect on primary and as well as secondary endpoint. So there seems to be no benefit on that. And the same thing, even the several one more meta-analysis shows that it has got no benefit. But mind you, there are some studies which have shown, especially in UKPDS and as well as the Harton study, they seems to be slightly favoring in metformin. So overall, if you can see that it is neutral, it is not cardio, it is cardio safe. That's what we need to understand. So the language should be that it is cardio safe, and we need not worry about using metformin, so that doesn't increase any cardiovascular. If not, if it's not cardioprotective, reduce it. Now, there are several other benefits that by using metformin. You can see that several inflammatory markers such as plasminogen activator inhibitor, fibrinogen, C-reactive protein, and a platelet addition and improvement in blood flow, all those things are benefited with metformin. So we expect the metformin to have some cardiovascular benefit as well. But though it has not been there, but you can see that these are the benefits that we need to consider for use of metformin. As far as the heart failure is concerned, if you can see that compared to the other sensitizer, glutathione, you can see that definitely the metformin usage without when you don't use any insulin sensitizer, you can see that metformin is beneficial in reduction in outcomes after say somebody is admitted with heart failure. No doubt, not all antibiotic agents are equal in their ability to CV risk. Only GLP-1 receptor analogs, SGLT inhibitors have been very beneficial, and rest of the medications that includes DPP-4, sulfonylureas, insulin, and metformin, no effect on CVD risk, but they are also cardio-friendly. Except saxagliptin, they are cardio-friendly. That is DPP inhibitors is cardio-friendly. That's what we need to understand. Right? Then, if you want to look into, though it's a small number in UKPDS, look at the benefits that we can get of metformin. So you can see that uh, any diabetes-related point reduction in 32%, diabetes-related death was reduced by 42%, all-cause mortality reduced by 36, myocardial infarction by 39, and microvascular disease by that close to 30%. In compared to sulfonylureas, you can see that the more benefit. The comparator, you just look at the comparator of metformin. So, friends, I would like to suggest that metformin is cardio safe for sure. Whether you expect benefit like what you see in UKPDS or not, it is a cardio safe. Don't worry about using it. Now, the other controversy that we have in many tricks that it has got is metformin in pregnancy. In metformin crosses the placental barrier, and that may affect the fetus. There has been the controversy that has been thought about and debated all along. But whereas in MIG trial, you can see that the gestational diabetes, where the metformin or insulin has been used for treatment, in women with gestational diabetes mellitus, metformin alone or with supplemental insulin is not associated with increased perinatal complications compared with insulin. The woman preferred metformin to insulin treatment. This is what has been the conclusion that has been come out. Now, later on, people started talking about metformin. The controversy is that what happens if this fetus is exposed in utero to metformin? What happens after they give birth? Now, then what they have done is that in the first follow-up of the mixed study, infants of women with GDM who have been exposed to metformin or insulin during pregnancy, these fetuses have been examined after 2 years of age. What has been found is that the offspring exposed to metformin utero has increased subscapular and bicep skin folds when compared with the unexposed infants, while total body fat was similar to every child. This hypothesis that a possible benefit as the signal of healthier fat distribution for those infants who have been exposed to metformin in utero. So again, the the controversy is laid to rest as far as pregnancy and the fetus is concerned. Now look into the lactic acid. This is another contentious thing. Lactic acidosis by guanines, especially in hypoxic conditions, and renal insufficiency as well as hepatic insufficiency. Then time and again it has been raised in debates. Now here is one a systemic review and meta-analysis that is published between January 1959 and 2002, where they have taken about pooled data of 194 studies in about 37,000 patients in the metformin group or in 30,000 patient years in the non-metformin group. What has been found in this particular concluded is that there is no evidence to date that metformin therapy is associated with an increased risk of lactic acidosis or with increased levels of lactate compared with other anti-hyperglycemic treatment. This is a fantastic conclusion of safety about metformin that has been given. Now, all along, okay, this is in general population. How about in renal insufficiency? Again, this is a retrospective cohort study. What they have been found is that overall lactic acidosis rate for patients on metformin in this study was within the range of rates reported in the literature of patients with type 2 diabetes. No significant difference was observed among patients with normal, mild, moderate, and severe renal function defects. This is how. So again, the lactic acidosis part of it, let us keep it to rest. Does, does metformin protect the kidneys like others can? Because in view of the latest drugs like the SGLT2 inhibitors and as well as GLP-1 receptor the genoprotective effects have been very well established. We cannot compare metformin to that. But one thing is that metformin, you can see that the recommendation says that metformin, according to the renal function as estimated by glomerular filtration rate, if the EGFR is, depending on EGFR is less than 30, you should stop the treatment. 30 to 45 half dose or don't initiate. 45 to 60, yes, you continue, and then but you be cautious, very important, because increasing monitoring of renal function every 3 to 6 months is necessary whenever you're trying to get into giving the patients with renal insufficiency. Avoid any nephrotoxic drugs and stop metformin if dehydration arises. Look at Indian conditions where NSAID drugs are left and right used without prescription, and also we have hot, humid conditions, and where the dehydration is very common. We need to be extra careful whenever we are trying to treat with metformin. This is not there has been a lot of change, in usage of it. You can see that there have been a lot of batting has been done to state that we need to change the guidelines for use of metformin, but we need to be extra careful. Now, are there any renoprotective effects of metformin, like what we see with SGLT2 inhibitor? No, in this particular study, they suggested that apart from anti-hyperglycemic, metformin could also decrease AG formation, advanced glycogen products, which are implicated in vascular complications in diabetes by reacting with alpha dicarbonyl compounds. So this is relevant to a potential clinical use of metformin in prevention of diabetes complication by inhibiting carbonyl stress, that is antioxidant effect of metformin. This you need to take that. Though we have in renal insufficiency, be careful, but it seems to be having a renoprotective effect before they develop renal insufficiency. Though the the guidelines say that be careful in using, and as American Diabetic Association said that less than 30 to be contraindicated, less than 45 you need to reduce the dose, 45 to 60 you have to be carefully watching, more than 60 no contraindication. So should restrictions be relaxed for metformin in kidney disease? No. We should never again compromise on safety because of the dehydration and nephrotoxic effects of other drugs that can happen. So it's a protective drug before you develop a renal insufficiency. But once you develop a renal insufficiency, you need to be careful. So this is a controversy, and this is the review and explanation that we can do as far as metformin is concerned. Now, in NAFLD, now there are several studies to state that metformin has no significant effect on NASH, like pioglitazone is superior to that. So it can be used in FLD without any hesitation. It does not hepatotoxic, but don't expect any thyroid. So the argument and the argument and the controversy is that whether it should be used in metformin or not, it can be used, but there may be no reduction in the fatty liver. That's what you need to say. As far as the old age is concerned, let us not worry about that. As long as the EGFR is normal or fairly normal, we can go ahead and using the metformin even in old also. So that controversy also has been settled down. Now the latest controversy, this is just in April or May, we had that the extended release metformin can cause cancer. It has become so popular in social media as well. This is basically because of in extended release preparations, it contains what is called as NDMA. We should not it should not cross the acceptable intake of limit. That's what has been done. But mind you that most of the companies, except a few, one or two companies even in the country, they have NDMA levels have been slightly increased, about 2 or 3 companies, not more than that in our country. And most of the other metformins are very safe. We need not worry about the controversy about the NDMA content, and it can be carcinogenic, which US FDA has come out with stating that. And one more thing is that understand that the another statement FDA, physicians are suggested not to stop the metformin which you already used. Till then you get a replacement where NDMA levels are within acceptable limits. So this is a statement. So again, the controversy as well as the explanation for the metformin has been there. So you can contradict. You can contradict. You can. What I would like to suggest to all my friends, the delegates, is that look into the situation of the patient and wisely use metformin. But still, metformin is a wonderful drug to be used. We cannot imagine good control of diabetes without metformin. Look into the contraindications more before indications. Thank you for patience here.